Hey, everybody. Welcome to another Sunday morning conversation. Today, my guest is Dr. Caroline Lindblad from the Karolinska Institute, and her research is about traumatic brain injuries. So thanks for tuning in, everybody. I appreciate it.
Hi, Eric.
How are you?
Hi, I'm fine. How are you?
Oh, it's a nice day today outside. I don't know. What's the weather like out there? I don't really know much about Sweden's climate other than it gets cold winter.
Oh, in Stockholm today, it's been a nice morning, then followed by kind of a grayish afternoon. We um we had been hoping for spring for some time now, but it was actually snowing all last week.
Oh, that's how it was up in my parents' house up in Ohio. Have you spent time in the States? Because you don't sound like you have much of an accent.
Oh, no, I haven't. I've only visited like once for tourism, but no.
You
I
sound you sound more like an American than like anything else. So I was just gonna say.
well, that's Netflix. Um, but no, I haven't.
So I
But
was
thank you so much.
yeah. So I was reading your research, and I know not just enough about research to be dangerous, right? Because I worked in a research lab for 4 years when I was at university, and I have a psychology degree. So I know a little bit, but just enough to be dangerous. Why don't you explain to me about, because you have a lot of different journals out there. I searched you through Google Scholar to see what turned up, and it's a little bit over my head.
Yeah, I would. So I've published a little bit. I'm quite in the research world. I'm still a junior researcher. I just finished my PhD studies. So kind of from my point of view, I've just begun to embark on like my scientific journey. But my key interest is in severe traumatic brain injury and what happens in the subacute phase of following the injury. So at the time of injury, there is of course mechanical trauma in one way, but this is later on ensued by the body's own response, one can say, to what has actually happened during the trauma. And this we call the secondary injury or secondary insults, which are due to processes undergoing in the injured brain, something we can call cellular injury processes. And that has been my focus of studies because we think that might be amenable to treatment, actually.
Yeah, and that's not the only one you've done though, because I've pulled it back up here. You're in there on the addition of hypoxia. I've met somebody who was a TBI patient. And that's why she's a TBI. Let's see.
But that's a rodent study. You know that is a review actually. The addition of hypoxia is so hypoxia is subnormal oxygen levels, right?
Yes.
And the addition of hypoxia is a review or a method paper where we describe how you can actually study this in rodent in an animal model system. So and that is that work where that review, which is it's a nice review, I think. It's a nice method paper, but it should mostly be attributed to one of my former co-supervisors, Associate Professor Erik Thulin. But what you can do there is you can study what actually happens at the site of trauma or the site of accident. But you have to do that in a controlled setting. And for that, or Eric mostly, developed a rodent model.
How
Um,
how often do you work with rodent models?
it depends. So I've done it to some extent, but I've tried to maintain a broad perspective so as to learn a little bit from all research areas. I think that it makes for a very nice interface where you can work with something of relevance for the clinical setting, whereas you can still retain like the study conditions in which you can explore more freely as you can in the animal experimental setting. Um, but it's I haven't done it to a super large extent, like a few smaller cities. But I think it's really ethically something you need to think a lot about. But without rodent models, without animal studies, it would be very difficult for us to pursue new promising treatment studies in the context of severe traumatic brain injury studies.
What made you want to look at brain injuries? What you got you into this?
It was by chance, actually. I was in med school attending a lecture. I had been to some extent interested, or I was interested in the coagulation system and in bleeding and in clotting factors in our blood. And I had been doing a previous study that was related to platelets, that those are like the clotting, the first cells to clot when we get a wound somewhere. And I had been working briefly with a method that I thought was really interesting, that assessed the function of platelets, which is quite seldomly used in the clinic. And then I attended a lecture on severe traumatic brain injuries, and the lecturer, who later on became a supervisor, a mentor for me, he mentioned this assay, and I approached him in the break, and he suggested we should start off something relating to that method. And that was actually how I stumbled into the field of severe traumatic brain injuries.
What do you like most about it?
That's a really big question. I like that it's really intricate and really important, and that there are so many things that we can do that I think may be of great value onwards.
Yeah, I noticed in some of your papers it says, you'll use the phrase something over and over again, like little is known about this or little known about that. What is something that you figured out since you started that is very surprising to you that you wouldn't have assumed it was going into this?
I am surprised. Like, before I embarked on this, I knew little of the available treatments. So from a broad perspective, I'm surprised of the extreme intricacy, the extreme complexity of parallel processes undergoing, and how difficult it is to grasp all of that at once. That is on a more personal level. On a strictly biological level, I would say that I'm not much surprised, but I was happy to be able to show in one of my papers of a certain injury mechanism that I think we have known for quite some time and studied in the context of, for example, multiple sclerosis, but not so much, but not utilizing the same techniques really, and not as actively in traumatic brain injury. But what I saw there was that the blood-brain barrier disruption, that is the shield, you can say, between the blood vessels and the brain, the fact that it breaks during a severe traumatic brain injury can actually be a prognostic factor for long-term prognosis. And that was something that it has been well studied in severe traumatic brain injuries because of other features that relates to this, such as swelling of the brain. But as far as I know, my work was one of the first to actually show crudely that this is something that actually affects prognosis. And that for me makes it, it's a sort of receipt for me to study this is important and also something that should be pursued. Because we want to, of course, target and focus our work on things that really matter in the long term for our patients, right? So that was something from a biological point of view that was a really important day that I saw the data.
Okay, what's the future look like?
You mean for severe traumatic brain injury research?
Yes, more specifically, yes.
I would say that I'm biased, of course, because I've been working a little bit with animals, a little bit with the cell, what we call in vitro studies. So I've been working a little bit in the strict lab environment. I've also been working with clinical materials in which you look into patient data. And I would say that to operate in that specific interface with a little bit of influence from both worlds, that is a really big thing that I think will help us bring new treatments, or I hope will bring new treatments for this patient group. So what I argue in my doctoral thesis is that we should try to understand and see, portray phenomenon in our patients. Then once we have elucidated them, we should take them to the lab, try to figure out exactly how it works, and then we should use that in order to develop treatments that we then assess, of course, first under really controlled conditions in the lab setting, and that we can eventually bring into the patient setting. And my long-term dream, of course, would be that we could have like a drug or a pill or a treatment that is super efficient. But what I think might be more realistic is that we have multiple different treatments that target different aspects of severe traumatic brain injury.
So out of all your combing through data, either in your data or of patients that you've met in person, no two TBI patients are alike, but what is the strangest one that you've seen so far?
Yeah, I don't think like patient-wise, I wouldn't express it like strange. I wouldn't describe patients as strange. I think I would rather say that there are marvelous stories, right? That there are tragic stories and there are marvelous stories, but there are those stories where we do not understand how the brain can retain such plasticity that we can see that what actually happens in the intensive care unit or in the critical care unit is not what is the actual final status of the patient in terms of autonomy. But then there are the really, really tragic cases where we don't have enough resources, and where we end up in a situation where we would not have wanted to end up. And what you're highlighting is a little bit the fact that you're saying this, no two TBI patients are alike. That is a huge source of frustration from a scientific point of view, because it's much more difficult to study heterogeneous conditions than homogeneous ones, right? Because we have all this noise inferred by the fact that the injury panorama is different between different patients. So that is a big challenge for us, actually, in my opinion.
So how do you anticipate overcoming that challenge?
Well, I think that a little bit like I highlighted before, that we have to start somewhere, right? So if we have a heterogeneous cohort of individuals, if there still are features that are shared between all patients, so disease characteristics, for example, if we can find signals in our data that is shared in spite of disease heterogeneity, that is something we should pursue. And then I think that is a trend across all of medicine, as that we're striving towards personalized medicine. So with more refined diagnostic tools, we can maybe to some extent individualize our knowledge surrounding each patient, and therefore target also each patient's specific needs. But it's still it is still a big challenge for us, and we're not there yet.
I mean, obviously, I don't know how your healthcare system works there. It's all socialized medicine, from what I know. We don't have that here in the United States. Ours is all based on insurance, and it's a pretty broken system. People like me, you know, in some states have it more difficult than others because we can't get medical insurance because it's tied to employment in the United States. And
Okay.
that makes it very difficult. Like for me, I was, I tried to go back after my accident 4 different times. I'm an architect by trade. I tried to go back 4 different times, and I kept getting fired because I'm essentially incompetent at being an architect anymore. But because when I was working as an architect, I was working more hours than everybody else because I couldn't process and operate in the same capacity. So I'm doing that, but I don't have the time to do rehab. And then when they would let me go, I didn't have the time, I didn't have the money to cover the rehab because I didn't have insurance. So I think, at least most European countries, ones with single payer systems or socialized medicine, they with people with brain injuries there are much better off because it's hard to retain employment while if you really have severe symptoms like I did. And I don't know if that factors into your research at all or not, but it is a major pitfall in our system here.
Yeah, no, I haven't. Um, there is a medical specialty which is called rehabilitation medicine, or in direct translation from Swedish, rehabilitation medicine or neurorehabilitation. And that is in a slightly different phase than what I've been looking into. So I wouldn't, I don't know so much about it, but um, we have a different healthcare organization compared with you, and I, as far as I know, but then I'm not an expert in this area. As far as I know, um, the vast majority, if not all, patients who have sustained a brain injury of such a severity that that you would need rehab or rehabilitation, there are such resources, right, for a varying amount of time. But then how that interacts and operates with other kind of social functions, that I don't really know, but for sure we have different systems, and and that is of course something. Access to rehab is of course something that affects um, what would happen, or as I hypothesize at least that access to rehab would affect a long-term outcome for our patients, right?
I would hope so. That's the whole point of it, right? So,
Mm.
I mean, I guess it would work for some, not all, who knows? But I mean, having that ability to get it is definitely one thing, and that's why our system is in the United States doesn't work for someone like me. And that's the thing with two different political parties controlling different states. Some of them have expanded their Medicare and Medicaid so that people like that, they do get better health care than I did. I happen to live in a very conservative slash regressive state. So they didn't expand that, which meant I was paying a lot of my own stuff out of pocket, which gets expensive after a while.
Yeah, I can. Healthcare is super expensive, as far as I know. We rarely see those bills, but that is as far as I've understood.
Yeah, and it's definitely messed up here. So what out of all your so in your whole time working on TBI research, what is a patient or a file that stands out to you the most that for someone's cause of their TBI? I know I had a doctor once tell me they met someone who had hundreds of pounds of cheese fall on them, and that was the strangest person
Um,
I saw with a TBI. What was yours?
so I actually haven't interacted so much with the actually affected individuals, but I've rather been going into medical records, and it might seem strange, but um, the actual mechanism of injury, I have not I haven't looked into it from that perspective. But so what I do is that I look into, is the trauma blunt or penetrating? and then following that, how of which magnitude was the trauma? Was it of such a magnitude so that the patient was unconscious at the scene of accident for a sustained period of time? And that is usually how I've structured my studies. That I've looked into blunt traumas. I have one article together with some of our collaborators in Finland on penetrating trauma. But I've looked mostly into blunt trauma, and then we have looked into patients who were unconscious at the site of accident, speaking in favor of a more severe trauma. But then, of course, there are always those underlying stories, but I don't remember them for one. And then secondly, Sweden is like such a small country, so I wouldn't want to disclose them even if I did remember them, because we do not have so many of those really severe cases, and that would I think compromise our confidentiality aspects a little bit.
No, I understand that completely. So all right, to get you out on here, what is one piece of advice that someone hasn't told me that would help someone like me that you could think of? What do you think is important that I should know?
A clinical advice or a research advice?
It can be either.
Mm, um, like a general clinical advice is to do as much as you can do. It becomes very rough now at the edges, but we'll work on it. Do as much as you can do, and try to always incorporate physical activity into what it is you're doing. So that is a sort of clinical advice, to kind of cherish what you're good at and what you're confident about, and then try to combine it with physical activity. From a research advice would be to be a cautious optimist. I think there is important work being done out there, but the vast majority of research takes a lot of time and is slow by definition. And it should maybe be slow also, because we shouldn't proceed with stuff until we have enough data to make a solid and robust decision on how to proceed. So research is slow. We should believe in it, but in a cautious fashion. So and retain some optimism. Was that what you were looking for?
Yeah, but to follow up with that, how do you think your research is impacted by additional diagnoses? Like obviously people with TBIs, a lot of them tend to develop depression or anxiety, or some have PTSD like I did. How does that affect your research? It's because it's an independent variable.
Yeah, so for the studies I have conducted so far, I mostly looked into the acute or subacute phase. In the subacute phase, the consequence of the actual TBI has not yet started to manifest themselves as far as we know. We're currently in the process of conducting a more of a follow-up project where we of course have to factor in all the consequences of a TBI. But so far in my research, I would rather say that we have all the comorbidities, we call it, all the prerequisite conditions that the patients come with when they have their TBI. So if someone has, for example, diabetes and then sustain a TBI, that is a factor that is difficult for us today to take account of. We're trying to do it in our statistical models, but it becomes tricky as the patients, as we already discussed, are very heterogeneous. But I think one of the key research questions for the future will be to, first of all, delineate exactly what can happen following a severe traumatic brain injury or any traumatic brain injury in terms of depression, PTSD, etc. And then if we can specifically target and hamper the development of those conditions? That I think will be crucial questions because there are so many people living in the aftermath of a traumatic brain injury today.
Yeah, I mean, I can definitely attest to that. Hey, Doc, thank you for joining me. I appreciate it. It's been helpful.
Yeah, thank you so much for having me, Eric, and good luck in your very cool channel.
Thank you, thank you. Yeah, it's going to be transforming into different stuff lately. I'm finishing up one project and starting another. See, that's part. Obviously, I don't know what my long-term future is going to be if I can't be an architect. But in the short term, I like to give myself this, since my TBI, like something that lasts like a year, 2 years, to work on to as like at least a short-term project till I can maybe figure out a long-term solution.
I think that's really strong, and also I would imagine that people who do not dare to speak so freely about what they have experienced can find a comfort and inspiration in your work.
Well, thank you. Thanks again, Doc. Enjoy your evening.
Thank you. You too. Bye.